All right, well, good afternoon, everyone, and welcome to today's webinar, The Growing National Burden of Autoimmune Diseases and the Role of Policy in Improving Outcomes. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. SWHR is a more than 30-year-old national nonprofit dedicated to promoting research on biological sex differences in disease and improving women's health through science, policy, and education. We're convening today's event to bring attention to autoimmune diseases and conditions, a group of more than 80 chronic and often disabling diseases that develop when the immune system mistakenly attacks the body's own healthy organs, tissues, and cells, and specifically their disproportionate impact on women. Before we move into today's program, I wanted to review a few details and housekeeping notes. First, we would like to thank Horizon Therapeutics for sponsoring today's program. Please also note that today's web event is being recorded and will be posted online. We will send out the recording and any resources mentioned in the follow-up email to all registrants. To ask a question to the panelists during this event, please use the Zoom Q&A function. Alternatively, you can use the chat function. We will ask questions at the end of the event following all panelists' presentations. And if you need technical assistance, please write that in the chat function as well, and note that we will have limited technical assistance available while the webinar is running. So today we are thrilled to welcome three incredible panelists who will share important information and resources pertaining to autoimmune diseases and conditions and where there are opportunities in autoimmune policy. We have Olivia Casey, who serves as a Senior Director, Programs for the Autoimmune Association, overseeing programs with a focus on ensuring the needs of stakeholders are met in an efficient and timely fashion. Her role includes the identification, planning, and execution of projects that focus on a positive impact for both the organization and patients. Quadricos Driscoll serves as Vice President of Public Policy and Government Affairs, where he spearheads the efforts to champion patient-first policies on Capitol Hill and unite stakeholders across the healthcare ecosystem to protect and improve key policies on behalf of people impacted by autoimmune disease. And prior to joining the Autoimmune Association, Quadricos was with the American Urological Association, where his efforts resulted in raising critical research dollars and driving legislation on behalf of patients. And finally, Dr. Sonia Sharma serves as an associate professor at the Center for Autoimmunity and Inflammation at the Center for Cancer Immunotherapy at the La Jolla Institute for Immunology. Dr. Sharma has an outstanding record of research accomplishments, including publishing high-impact discoveries in top scientific journals and establishing the Institute's Functional Genomics Center, which she currently directs. Dr. Sharma's work, particularly her studies of antiviral and anti-tumor type 1 interferon signaling, and she is channeling her expertise to further her own research program. Her work, particularly those studies I just mentioned, will be instrumental in understanding how genes contribute to human health and disease. And with that, I will turn it over to SWHR's Chief Advocacy Officer, Lindsay Horan, who is moderating today's event.
Thank you so much, Katie, and good afternoon, everyone. As Katie mentioned, autoimmune diseases and conditions have a disproportionate impact on women. Not only are 80% of the patients diagnosed with autoimmune diseases women, but women face a greater burden of disease. As described in a 2022 SWHR commentary, this greater burden of disease can be the result of gender and cultural influences that have psychosocial effects and can create expectations of caregiving for children's partners and parents who may suffer from chronic conditions. SWHR's Autoimmune Policy Program was developed to examine policy measures that create barriers to access and affordable care for women across the lifespan that are living with autoimmune diseases and conditions. Over last fall, we assembled a working group of researchers, healthcare providers, patient advocates, and policy experts who are really committed to driving change and improving care for women living with these diseases and conditions. And informed by that roundtable, SWHR developed a policy agenda to highlight how the implementation of key policy measures spanning areas from research to healthcare access and coverage could really yield tremendous benefits that ultimately lower healthcare costs, improve health outcomes, and advance health equity. Our hope is that this policy agenda can be a useful resource for policymakers moving forward, identifying ways that they can support women living with these diseases and conditions. And so following the presentation from today's guest speakers, I'll review the contents of this agenda and then lead our panelists in a moderated discussion. As Katie mentioned, we invite you to submit Q&A at any point during the presentation using the Q&A or the chat function. I'll now turn it over to our first speaker, Dr. Sonia Sharma, who will start us off with an introduction on autoimmune diseases and the growing burden of these conditions in the United States and across the globe. Thank you so much for joining us.
Thank you so much, Lindsay, and I'm really delighted to present and to share this important information. So I'm just going to share my screen. Okay, and as Lindsay mentioned, the topic of my talk today is really to introduce you all to the concept of how we think about sex-based differences in autoimmune disease and really what we call the X and Y of disease, because as an immunologist at the La Jolla Institute for Immunology, research like myself really try to get down to the molecular underpinnings of what we feel are really these obvious differences in diseases such as autoimmunity. Even though they're obvious, you'll see throughout my talk that there's really so much to do in terms of really understanding what the molecular underpinnings of these obvious differences. And so the challenge is to understand just sometimes the simple fact that disease affects men and women differently. Autoimmune disease affects men and women differently. And in that, there are profound sex-specific differences between women and men regarding some of the most common autoimmune or autoinflammatory, if you will, diseases. However, in contrast, many of the disease treatments are one size fits all. They don't even take into account that there are these profound differences, not only in the numbers of men and women who are affected by autoimmune disease, but also the symptoms, the onset, the type of disease, and probably what's causing the disease too. So just by logic, we would think that treating these diseases would be different, but there's a gap there. And as I said, most of these diseases really affect men and women differently. And understanding these differences can uncover new disease origins, lead to better prevention, and deliver personalized treatments. So here I'm just showing you a schematic of of maybe the top 7 autoimmune diseases such as Hashimoto's, lupus, cirrhosis, scleroderma, rheumatoid arthritis, multiple sclerosis. These may be very different diseases, and you're looking at the proportion of women versus men who are currently afflicted with these diseases. And you can see that there's a great bias in how these diseases affect women and men. For example, multiple sclerosis has a 2-to-1 women to men incidence. There's 2 women affected for every 1 male currently, all the way down to Hashimoto's thyroiditis, where there's a 10-to-1 skew. And you really can't ignore these numbers that are telling you that not only, again, does autoimmunity affect men and women differently, but it might actually be different diseases. Shown another way, we're looking here currently, depending on how you define an autoimmune diseases, we can say that there are approximately 24 million cases currently in the USA. There can be more if you add other conditions, but the numbers are the same. There's still a skew towards women in the sense that currently out of those 24 million, 18 million affected individuals are women and 6 are men. So what does this translate to? This is actually a leading cause of death in girls and women. Cases are mostly increasing. And there's this clear sexual dimorphism, you can see it right there, that's caused by unknown differences. And we think, and at the La Jolla Institute for Immunology, where my research is conducted, that we think these are fundamental differences in the immune system. And this really represents a new frontier of immunology research, as well as biomedical research. I'm not going to go too much in detail about what we know about specific sex differences in the immune system, but I just want to remind you that autoimmune disease is an immune disease. I mean, it's right there in the title. And so we know that differences or changes or dysregulation in the immune system is the primary cause of autoimmune disease. And in general, a lot of research over decades has shown us what we're looking at here is that for each different type of immunity that we have evolved to fight off pathogens, women actually have, you can see by these arrows, we have in general more immune cells that are circulating in our blood. And these are the cells that cause inflammation and that cause autoimmunity. So then in general, we can say that women are more prone to autoimmunity and inflammatory diseases. And you saw that in the schematic, whereas in contrast, men lack a robust immune response to pathogens. And this is when we compare them. This is research that we know. The details maybe not so much, but let's focus on the diseases. For example, we talked about men lacking a abundant pathogenic response, and we see this in acute or severe COVID-19. In fact, there's a 10 to 20 higher mortality rate for men globally. They are more prone to severe COVID infection. But this is an autoimmunity webinar. What about long COVID? Long COVID actually more mimics what we would call classical autoimmunity or classical autoinflammation. And women are globally 20% more likely to experience this autoimmune-like long COVID symptoms, which can really affect almost any different organ, including the brain. Cardiovascular disease. This is the #1 cause of death for both men and women. There's vast differences in how this is not an autoimmune disease, but some of us think of it as an inflammatory disease because it does have cardiovascular disease has underpinnings in the immune system. And there are vast differences here. For example, before menopause, women have lower cardiovascular disease than men. That is true. But at post-menopause, as women age, that risk is actually reversed. So again, different diseases. There are different symptoms. Classic chest pain or angina is a classical symptom of cardiovascular heart attack in men, but that's actually lacking in women. So again, these are almost different diseases. I'm just showing you this picture because I did a web search of heart attack or cardiovascular disease. And you can see in these photos that classic angina, heart pain, that's the most strongly associated image and symptom that we have. But this rarely occurs in women. So there are many women who are being misdiagnosed for their heart attacks because this symptom it's not really clear to even a lot of clinicians that this symptom is not present in all individuals. What about the brain diseases? Well, I can tell you that and this is a topic of research that my lab focuses on, is sex differences in neuroinflammation. These are diseases of the brain that involve the immune system and inflammation, such as Alzheimer's disease and Parkinson's. And these are very interesting because, for example, Alzheimer's and also what we call frontotemporal dementia or vascular dementia, this shows a 2-to-1 bias in women compared to men. No idea why, although we do know that scarily, the increase of this brain inflammatory disease is increasing. In contrast, Parkinson's shows the opposite. There is a 1 to 2 men, for every 1 woman who has Parkinson's disease, there are 2, or ALS, there are 2 men. But we don't understand why. And this is where, again, this need in the research community, the medical community, as well as the community in general for knowledge requires more understanding. So I hope I've convinced you through my talk that, that autoimmune disease and inflammatory diseases are, even if they have the same title, can be affect men and women differently. And in some cases can be considered to be different diseases. I want to take a step back and really talk about clinical trials, because it's through drug clinical trials is how we develop treatments and approve treatments. The history of women's participation in clinical trials is actually quite murky. As late as the 70s, there were very few women working in what I would say high level or decision-making positions in medicine or science. And this is just the truth. And this helped to contribute to a general belief that the specific health needs of women were perhaps not a high priority in the overall scientific and medical fields. In 1977, the FDA policy actually recommended excluding women of childbearing potential from clinical drug trials. And this was a broad policy. It actually excluded pregnant women, women on contraception, single women, and even women whose husbands were vasectomized. So really kind of too broad. This came from a good place in the sense that the policy was actually initially adopted due to the horrific events surrounding the incidence of birth defects due to the experimental anti-nausea drug thalidomide. But however, you can see that this had this unintended side effect that excluding women from clinical trials led to a shortage of data on how drugs specifically affect women and an absence of sex-specific therapies for autoimmunity and other disease that we know affect women differently. The good news is that in 1993, Congress wrote the NIH Inclusion Policy into federal law through a section in what's called the NIH, the National Institutes of Health Revitalization Act. And this is titled Women and Minorities as Subject in Clinical Research. What does that mean? What that means is that this law now ensures that women and minorities are included in all clinical research. In trials that include women and minorities, the trial should be specifically designed and carried out so that it is possible to assess whether the drug being studied or the drug effect being studied affect women differently than it does men, and as well as other minorities. And cost is no longer an acceptable reason for excluding women and minorities. If you ask me, this is an amazing landmark event. Maybe it's a little bit too late, but what that means is there's potential. There is still so much to do. And that includes including women as what women are not a monolith, including diversity. And better diversity in clinical trials makes the science better and makes health better. And I'm just going to stop there. Thank you so much.
Thank you so much, Dr. Sharma. That was a really fantastic presentation and really appreciate you distilling all of that information for us here today. So I'd now like to turn it over to our next set of speakers today, Olivia and Quadricos from the Autoimmune Association. I will turn it over to you and thank you both for being with us.
Thank you so much, Lindsay. And thank you everybody for attending. And thank you very much, Dr. Sharma. That was a fantastic presentation. I really appreciate that. Last year, the National Academies of Sciences, Engineering, and Medicine issued a report in response to a congressional request made in 2019 to evaluate the current status of autoimmune disease research and to make recommendations for the National Institutes of Health as to how to best address this growing need. As a result, Congress issued a recommendation to establish an Office of Autoimmune Disease Research and the Office of Research of Women's Health. Quadricos is going to explain this later in the presentation, the specifics on the policy implementation. I want to provide some of the background on why this effort is mission critical and why we should coalesce around this new office. Next slide. Let's go to the next slide. Okay, increasing number of patients. For anyone who works in this field with autoimmune patients, it's clear that we're in a growth industry. We know autoimmunity is on the rise, but right now we don't have a great deal of hard data on what the numbers actually are. Exactly how many people have an autoimmune disease or immune-mediated disease in the US today is debatable, and there's not a lot of consensus. One recent NIH report states that we are now experiencing an autoimmune epidemic. Next slide. I wanted us to review a little bit of the incidence and prevalence. The Autoimmune Association lists over 150 autoimmune and related diseases in our database. Many of these are recording increasing incidences. For some of the diseases with more accurate data, the increases are stark. Here we can see some of the dramatic domestic incidence increases for 4 autoimmune conditions. Next slide. These numbers reflect some global prevalence of specific autoimmune diseases. Examples of the increasing prevalence around the world over recent decades. The estimates for the time periods are connected by lines to visualize these trends. The data sources are for psoriasis in Canada, type 1 diabetes in Denmark and the United States, celiacs in the US, MS in Canada, primary biliary cirrhosis in the US, all inflammatory bowel diseases in the US, and the rest are from Korea. So we can see these spike lines pretty dramatically. Next slide. Okay, total numbers all over the map. Johns Hopkins estimates 10 million or 3% of the population, with the caveat that they do not really know how many. That's from their website. According to the Nasim Report, the last study that was considered autoimmune diseases was published in 2009 and estimated the prevalence of disease to be 7.6 to 9.4% of the population, or 25 to 31 million people today. This estimate was based on only 29 autoimmune diseases and does not account for increases in recent findings or emerging conditions, certainly not the greater than 150 diseases that we reflect. Okay, let's compare this to Canada, where one study, and Canada obviously has centralized medicine, one study estimates that 16% of Canadians have at least one autoimmune disorder. That correlates with approximately 53 million in the US. Now in 2020, and in a very non-scientific approach, and this would not withstand rigor by any means, an Autoimmune Association researcher took 111 autoimmune conditions and pulled all the NIH incidence and prevalence data, discounted for multiples, and came up with approximately 80 million patients. It indicates there's a lot of people out there who suffer from autoimmunity that are uncounted, be it one or multiple diseases. Now, I have had researchers concur that the number is not shocking and indeed could be higher overall if all autoimmune related conditions are taken into account. And these are diagnosed patients. If we consider there's an average of 4 to 4.5 year journey to diagnosis overall, we have exponentially more patients. They may not have a firm diagnosis, but they're patients nevertheless. Next slide. There's another issue. Increasing ANA tells us there's no sign of decreasing overall numbers and suggests a future increase overall. In 2020, NIH researchers found that the prevalence of antinuclear antibodies, ANA, most common biomarker of autoimmune conditions, has been and is on the rise. Now, to be clear, autoantibodies alone are not diagnostic for disease. They do define the presence of autoimmunity, and they're some of the best predictors in the development of autoimmune disease. They utilized for their research the NHANES data, the National Health and Nutrition Examination Survey, which is a CDC program of initial studies that started in '59. And they utilized, using this data, they found the prevalence from 88 to 91 was 11%. The figure rose to 11.5 between 99 and 04, and then 11 to 12, the percentage has spiked to 15.9% overall. Extrapolating those percentages would result in 22, 27, and 41 million Americans affected respectively. Now, of particular alarm is the youngest cohort, from 12 to 19 years old, which experienced an almost threefold increase in those three data points. Children who may well be subject to a life of chronic illness. Why is this spiking? Well, the research indicates that the probable causes for such increases include the major recent changes in our foods, contact with xenobiotics, air pollution, infections, lifestyles, psychosocial stress, and climate change. Even the recent wildfires may have an impact, we just don't know. This also supplants the theory that increased physician recognition of autoimmune diseases alone may be causing their apparent overall increase in numbers. Diagnostics are hopefully improving, but the underlying increase in numbers is still there. Next slide. So how much is this costing us overall? There is little data on the direct and indirect costs in the US of specific autoimmune diseases, but I did find some annual estimates in the report from association members that indicate the approximate costs, which we can see here. Now, one RA study that did include both direct and indirect costs estimated a total of $47.6 billion in 2005 dollars. And the way they broke it down was 8.4 for direct, indirect, including lost wages, job turnover, required household help at about 19.3, intangible costs relating to quality of life changes about 10.3, and then premature mortality at 9.6 billion. So these are quite costly. Next. Okay. In 2001, the National Institutes of Allergy and Infectious Disease, NIAID, estimated that the annual autoimmune disease treatment costs were greater than 100 billion. or in today's dollars, $168 billion. This references the total applicable number of patients that were marked at that year at 20 million. And that really captures a fraction of the cost because that same year, Crohn's, ulcerative colitis, lupus, MS, RA, psoriasis, and I never get this right, scleroderma are estimated through studies to be from 51 to 70.6 billion. So with 150 diseases, most likely this is a gross estimate. But so for reference, what does this mean? So for reference, as a nation, we spend on the VA, the Department of Energy, and NASA combined the same amount, roughly. It's costing us a fortune. Now, some recent forecasts have indicated that this number could be as 500 billion. And if we think of that, that's about 2/3 of what we spend on Medicaid altogether to take care of about anywhere from 30 to 80 million people. Next slide. So compare those figures to what is spent overall on autoimmune disease research by the NIH, which in FY 2020 was $1,083 million. Note that this has remained relatively static since 2009. In fact, if we consider real dollars, it's actually decreased. Next slide. How does this stack up against the rest of NIH obligations? It's remained at approximately 2.8% since 2008. So we haven't gotten much of the monies. Next slide. So we have an increase in incidence and prevalence without consensus on how many actually have autoimmune disease, nor how many patients. We have a known increase in direct cost that we can measure, and we have a flat line on spending. Add to this what I call the cycle of information deficiencies, a lack of consensus definition, a lack of reporting, and a lack of overarching strategy. Next slide. We can't measure what we can't define. There's no consensus regarding the boundaries of definition of autoimmune, autoinflammatory, immune-mediated, or immunodeficient diseases. These terms are broad and used differently by different groups. Patients living with autoimmune disease usually do not consider autoimmune and autoinflammatory conditions together, while clinicians and investigators may consider them similar and common enough to think of them as one entity or two closely related entities. Physicians and clinical researchers classify autoimmune diseases according to symptoms and laboratory abnormalities. Basic science researchers classify autoimmune disease according to more inclusive biological mechanisms. Recent scientific advances regarding cellular and molecular mechanisms of tissue injury have blurred the line between autoimmune and autoinflammatory diseases, making differentiation between the two difficult. And diseases that science has not historically considered to be autoimmune, such as Parkinson's or cancer, have autoimmune mechanisms. The result is we do not have a comprehensive definition or consensus vocabulary what is or is not autoimmune. Next. Reporting, data registry. There's no mandatory reporting system or national registry for autoimmune diseases. Existing incidence and prevalence data often comes from other countries that have healthcare systems covering the entire population that may not distinguish sex and gender. The countries may not reflect our diversity and may be racially and socioeconomically homogeneous. They do not necessarily reflect the diversity from Detroit to Salt Lake City. Because we have limited ability to assess trends, we also can't clearly identify the prevalence and incidence of under-researched autoimmune diseases and conditions such as celiacs. This obviously limits our understanding of incidence, prevalence, and trend analysis. As an example, a study proved that the 10-year mortality rate in an incidence cohort of lupus in Georgia was 28% in Black persons and 9% in white persons. How does this correlate nationally? Well, we don't know because we don't have a method of systematically collecting that information. And although not specifically tied to a registry, studies have demonstrated considerable underreporting of autoimmune disease as a cause of death. It is difficult to quantify mortality in most autoimmune diseases since death more commonly results from and is recorded as being a result of complications such as cardiovascular disease, infection, or malignancy. Mortality statistics are difficult to ascertain. We lack a long-term, which is 20 years or more, population-based epidemiology study on autoimmune disease that would allow us to assess these trends. Next. And finally, and most critically, we do not have a centralized strategy. The NIH is the primary funding agency for research. 12 of the 27 institutes and centers, ICs, undertake the majority of all autoimmune research in the US. Each IC has a different mission, sometimes they're overlapping, and frequently each has a different research priority and focuses on different autoimmune diseases. The reporting formats are not standardized, nor do they indicate how they choose diseases. Some listed diseases are common, such as RA, the focus of NIAMS, and some are exceedingly rare, such as autoimmune encephalitis, a focus of NINDS. But there is no comprehensive, transparent, or strategic approach on how it plans and evaluates progress made on autoimmune disease research as a whole. The way they are dispersed across the ICs may lead to siloing of efforts if there is no systematic attempt to coordinate activities across the NIH. And the funding issue. We've seen that despite overall NIH increases in the NIH budget, the percentage of spend going to autoimmunity has remained flat. There are limited resources, and currently, without a coordinated strategy on budgeting and prioritization, it tells us we have a looming crisis. Next. This leads us to the Nasim Report, which was comprehensive. If you haven't read it, I strongly encourage you to do so. It's fascinating. This was done by a committee of researchers, clinicians, and scientists who returned the report, and they also came up with the following essential elements that are necessary for rapid advancement improving in research, which was planning, coordination, innovation, portfolio evaluation, and funding. Next. There were actually 6 separate recommendations that they made for how to advance the solutions. I'm gonna briefly go through the 5 that didn't make the cut, because it's interesting to know the thought behind what did actually make the final cut. Which the first one was increased funding for autoimmune disease overall, which would have been a standalone. The second was update the 2002 autoimmune disease strategic research plan with a new planning process. The third was revitalize the HHS Autoimmune Disease Coordinating Committee. The fourth was establish a new congressionally mandated National Autoimmune Disease and Autoimmunity Plan, which would have required specific congressional approval and authorization, which is way too time consuming. And then the last one was create a new National Institute of Autoimmune Disease Research and Autoimmunity. They were all very worthy recognitions. Each came with drawbacks, but the last one with a price tag that realistic was simply not going to happen. Next slide. I'm going to briefly go through what was the final recommendation. The winning recommendation called for the creation of an Office of Autoimmune Disease, Autoimmunity Research within the Office of the NIH Director. Now, this option is not a new one, as it was proposed in a bill advanced by then Senator Joe Biden in '99. So it's one that's already familiar to many. The office would have been responsible for suggesting and creating new scientific approaches, partners, and paradigms, and functioning as a hub and spoke of autoimmune research. They recognize that what will drive the success is the budget. So there are 2 historical precedents that they reference in their discussion. The first is modeled on the Office of AIDS Research, which has its own research budget and makes its own budgetary decisions. In this scenario, a new office would substantially control and coordinate research and budget for autoimmunity elsewhere in the NIH. The second model would have been reflective in the Office of Research of Women's Health. In this configuration, the office would have some responsibilities, but limited power and resources to carry out the mandate. The Office of AIDS Research model was considered in the report to be the most effective. Congress selected a hybrid by placing this office within the ORWH, which is where the office will be stood up. We'll go to recommendation number 2. Next. The data collection that, again, the committee recognized we need more data, and we need the collection to be longitudinal. Recommendation number 3. This goes to the future of data analysis, which is develop a population cohort that extends from the period before the disease manifests itself to the development of symptoms to facilitate the examination of the progression coexisting morbidities, and long-term outcomes of autoimmune disease. And there were specific recommendations that were under that bullet. And recommendation number 4, establish an overarching strategy. But before we do that, establish a working consensus definition that needs to become the foundation of all the recommended action items. And the industry partners need to have a seat at the table, ensure that they are participating in this effort and their voices are being heard. This is also seen as international, that the international stakeholders need to be involved in this effort as well. Next slide. So where are we now? Quadricos is going to get more into the policy, but here we are with the 6 directives from Congress, which is to occur within the ORWH. 10 million is budget in funds was awarded to help stand up the office, which is not trivial. Well, that's not a trivial task and not one that will happen overnight. Next slide. So if we look at the language side by side from the report and from the congressional mandate, essentially Congress has mandated phase 1 as reflected in the recommendation in the report. It's not specifically what the very esteemed committee members had called for, nor does the funding reflect such dire need, but it's a start, phase 1. There is now a home for autoimmune disease research. It's strategically situated where it is effectively in a safe haven, and it behooves us to help stand it up first and quibble over the details later. We are better served messaging support as a united front in order to preserve what is on the table now, understanding this is a long process and will take many years, and it isn't going to happen overnight. There will be many decisions pending, and that's okay. As advocacy organizations who lobby on behalf of patients who are seeking diagnosis, treatment, and cures, and maybe even prevention, it's incumbent upon us to support the research community as a whole. The recommendations in the report come from within that community. If we want to support our patients, it would seem to me we need to support the mechanism that will benefit them, the researchers. It is a start in the right direction and likely all that can be done politically for right now. And it does have the possibility of growing and becoming more independent in the future. Now, Quadricos is going to do a deeper dive into the policy.
Thank you, Olivia. Dr. Sharma and Olivia have clearly outlined the fact that we know that autoimmune conditions, immune-mediated immunocompromise affect men and women differently. Olivia, of course, has addressed the fact that there is no really consensus around these definitions, and still yet more research needs to be done. With regard to that and the moving forward of this office in bringing together immunology community, the autoimmune, immune-mediated immunocompromise community together, we worked very closely with Congress on the development of this report language in consultation with Dr. Betty Diamond, who is the chair of the Scientific Advisory Board for the Autoimmune Association, and who was one of the principal investigators of the report. So phase 1 has been actually having the conversation with Congress to develop this report language. Back in May of 2022, we worked with Congress to develop the report language, which I'm not sure if you can see the verbiage there, but essentially we called for the committee, the Appropriations Committee specifically, to recognize what the National Academies of Science, Engineering, and Medicine recommended, which was, of course, a congressionally mandated plan to fund an office of autoimmune condition where everything is coordinated under that office, under the director of the National Institutes of Health. That approach in conversation with Congress, that was conversation regarding statistics, regarding the fact of women being disproportionately impacted by autoimmune, immune-mediated conditions, and as such led to the current report language. Next slide, please. Which is the report language that was drafted from Congress. Again, I'm not sure if you can see that there, but essentially, Congress, based off of the conversations we had with them, essentially went back and put a $10 million price tag. Now, fundamentally, that $10 million is really just to set up and to implement the office. per, again, the recommendations of the report. And the difference versus the report language that we submitted to Congress is now, as Olivia mentioned, it would be housed under the Office of Research of Women's Health. Now, there is some consternation with regard to some of the groups that we are working collaboratively with about whether or not it is the best place to have the Office of Autoimmune Disease Research within the Office of Research on Women's Health. Again, we believe that Congress placed it under the Office of Research on Women's Health because of the statistics with regard to the fact that autoimmunity disproportionately impacts women. Though, of course, as Dr. Shermer, as I mentioned earlier, has presented, we know that there are biological and even ontological differences, but yet there seems to be this one-size-fits-all treatment. Next slide, please. So next steps. We know that report language, frankly, is a directive to departments and to agencies with regard to what Congress recommends they should do. Right now, the Autoimmune Association is working in tandem and collaboratively with disease states, particularly named in the report, on what is best for this Office of Autoimmune Disease Research. And that includes finding an ideal location for the office, in short, for it to flourish, and making sure that the research and the patients that we serve are treated appropriately, and the disparities with regard to gender, but also to race, are addressed. So we are working in tandem and collaboratively, providing education and awareness for this Office of Autoimmune Disease Research under the National Institutes of Health, why it is important. As Olivia mentioned, this is not the first step, but this is the first step in a very long time where the autoimmune community, immune-mediated community, is coming together to really begin to put pressure on NIH for the establishment of this office. And so we are working in tandem. And one of the efforts that the Autoimmune Association is doing is working within one of the coalitions that we manage, which is the National Coalition of Autoimmune Patient Groups, on a virtual fly-in, where certainly this will be one of our asks. We know that other patient advocacy organizations that we're working with will also potentially have this as one of their asks as well. And so we seek ways to work together to move this initiative forward, which we know certainly will be a long-term strategy rather than a short one. Next slide. And that essentially ends our presentation. I believe there is still time and room for questions, and so we are welcome to take questions should there be any. Thank you.
Thank you so much, Quadricos and Olivia. Each time I hear you speak, I am amazed. I learn something new. And I'm constantly shocked by the discrepancy in terms of how many autoimmune diseases it's classified that there are in the United States and globally. And Olivia, I thought some of your comments on the increasing direct and indirect costs were really interesting. So recognizing the time, I will briefly walk you all through the autoimmune policy agenda, and then we'll open it up for a few questions. So the first thing I'll say is during last fall's autoimmune policy roundtable, there was a lot of overlap between the various stakeholders on certain policy areas within the autoimmune disease space. But at the highest level, I would say that we were all in agreement that federal policy must prioritize autoimmune diseases and conditions to try to curb the effect that we expect it to have on the population more broadly. And it's worth noting that between the rising rates of autoimmune diseases and conditions in the US and globally, their impact on women, and the fact that the treatment of autoimmune diseases and conditions really centers on managing the symptoms and slowing the progression and impacts of the disease, policy can really have a real impact on health and quality of life outcomes. And we aim to showcase that in this policy agenda. So I'll quickly walk through the policy agenda itself, and I'll note at the outset that because of time, I'll be discussing it at a very high level, but we will be including a link to it in the chat of this webinar so you can view the agenda at your convenience. We'll also share it after the fact. But the first section of the autoimmune policy agenda focuses on research needs and opportunities, which are vast. I'll note that the working group members were reticent to name particular areas of research that would benefit from increased research funding because, as they put it, research is needed in all areas of autoimmune diseases and conditions. But SWHR did choose to name a few in our policy agenda, including research into the mechanisms influencing the increasing incidence of autoimmune diseases and conditions, and the role of biological sex on the development of autoimmune diseases, symptom severity, and symptom manifestation, which Dr. Sharma commented on in her opening remarks. In this section, we also called attention to the need to meaningfully improve diversity in clinical trials so we could ensure that our understanding of autoimmune diseases and the subsequent treatments and interventions that are developed work for everyone, regardless of sex, gender, race, or ethnicity. In the next section, education, awareness, and advocacy, SWHR called out the importance of flexible workplace policies to allow those with autoimmune diseases and conditions to be supported and to excel in their respective careers, as well as the need to promote health literacy and for federal agencies to explore how they are developing and sharing public health information. Within the clinical care needs section, there were several areas called out as areas of need, but among those that were identified were the need to incentivize the creation of multidisciplinary care teams to ensure that autoimmune patients have access not only to their rheumatologist, but also to other providers who may be a part of someone's care paradigm. So that includes people like physical therapists and nurses and dietitians and occupational therapists and mental health providers. Additionally, we called out the need to improve electronic health record interoperability so that people could easily access their healthcare information, and the need to expand clinical education to increase awareness of autoimmune diseases and conditions. And then finally, when it comes to coverage and access, we noted a few areas where policy would be really critical for supporting patients. So this section discusses utilization management policies, in particular prior authorization and step therapy, and how those policies can result in delays in care for patients with autoimmune diseases and conditions, leading to disease progression and higher costs over time. We also called out a few of the policies that have been introduced in the most recent Congress and how passage of those policies could support patients. This section also touches on incentivizing physicians to practice rheumatology. There is an expected workforce shortage for rheumatologists, expanding access to telehealth services, and then ensuring transparency from health plans about patients' overall contributions to any out-of-pocket maximum or cost-sharing requirements. So those were just a few of the areas that were touched on in the autoimmune policy agenda. As mentioned, we will be including it in the chat so you can view it in more detail. And of course, if you have questions, feel free to contact me. I'll also drop my chat or my email address in the chat as well. But I do want to ask a couple questions to our panelists before we leave for the day, and we'll also be looking for different audience questions. So one thing I'll ask is, given that this is kind of a policy discussion, for those on the phone who would like to see some of these policy recommendations implemented at the federal or state level, how might people go about advocating or championing some of these causes? Are there groups they should tap into? What resources are available to them? So maybe Quadricos, we'll start with you, and then Olivia and Sonia, if you have anything to add, please do so.
Sure, that's a great question. I certainly would recommend connecting to, for one, obviously the Autoimmune Association, but also to the various disease states within autoimmunity with regard to the work that they're doing to address not just the utilization management tools that are in Society for Women's Health Research report, but generally that impede access. When it comes to the report, generally speaking, there are a lot of people within the autoimmune space that frankly just aren't aware. And so one of the things that we plan to do is just call attention to that. And I think what a patient can do and what an advocate can do is call attention to this report and to the efforts that we are undertaking, again, in collaboration with a number of disease states. Rheumatoid arthritis was mentioned in the report, psoriasis was mentioned in the report, multiple sclerosis, Crohn's and colitis, and we're working with those disease state organizations to ensure that there is congressional pressure to NIH to ensure that the recommendations, particularly the Office of Autoimmune Disease Research, is actually implemented. And so with that, I think calling your members of Congress, advocating at the state level, participating as many webinars about this as possible, joining us, the Autoimmune Association, in our efforts to talk to your members of Congress about this, and just really raising awareness about this office and why it is important. Clearly, I think Dr. Sherma and Olivia and others have outlined the need for this. And so right now we are in raising awareness, but it's going to take much more than raising awareness to actually implement it. And that's where congressional pressure comes in. And the truism, and I'll end by saying this, the truism is still true that members of Congress and policymakers, both at the state and the federal level, still listen to their constituents.
Thank you so much. And I think that's so important. And one thing I'll note, and I think I speak for Autoimmune Association, is any of the resources that we have available on our websites as you're going to meet with members of Congress, you should feel free to use those and take those to your congressional, your meetings with your congressional delegates. So please feel free to use those resources. Olivia, Sonia, anything that either of you would like to add to that response?
You know, the one thing that it strikes me is I hear this over and over, which is to educate the broader population on the prevalence of autoimmune diseases. And if you talk to people, you realize how prevalent it is because you talk to someone. And I was at a informal gathering and had a casual conversation with a woman who was telling me about how her son, who's 12, had a 2-year journey to diagnosis for Crohn's disease and what that was like for the family. And then she was talking about how many in her family had autoimmune disorders. And she didn't realize how prevalent it was. Overall, she said, I just thought I was by myself. I thought I was alone. I don't know, you're not alone. So educating the population at large to make sure that they are educating the people for whom is supposed to be working for them at the congressional level. I think that's imperative. And I completely support what Quadricos is saying about make them accountable.
Thank you so much. So kind of as we wrap up, based on the conversation that we had here today and the information that each of you presented, what is one takeaway that you would like to emphasize, whether it is to policymakers directly or to our broader viewers, about autoimmune diseases and conditions and the policy implications surrounding them?
I'll just quickly chime in here with regard to advocating to policymakers. Share your story. I think sharing your story and you living with multitude of autoimmune conditions or one condition is very important. And it's important because policymakers need to understand how some of the utilization management tools like prior authorization and step therapy are impeding care, but they also need to understand why such an Office of Autoimmune Disease Research is important and it's needed.
Olivia?
Single takeaway. Yeah, for a single takeaway, I would have to say it's education, education, education. And I would completely agree, tell your story and don't be afraid to tell your story. And share your story with other patients and with your congressional representatives and make them accountable.
And Sonia?
I guess my takeaway would be the issue is real, it's there. I'm hearing advocacy, I'm hearing education, and I want to emphasize that your basic research community, such as myself, are always here as an additional resource. So find your local university, nonprofit organization, and please reach out to us because many of us, most of us, are happy to educate you on what's going on the basic research side.
Thank you so much, Sonia. And I think that's a resource that people don't often think about. And I'm really glad that you've made that you've made that plug for universities because, you all are really experts and, working in this space day in and day out and can really talk about the research needs and opportunities. So thank you so much. With that, I would like to thank our panelists again for joining us this afternoon. As was mentioned at the top of the webinar, this webinar has been recorded and will be posted online following the event. If you have any other questions, please feel free to reach out to the Society for Women's Health Research. We can connect you with our panelists as appropriate. And, this is one webinar of a series that we'll be hosting and follow up from the roundtable discussion that was held this fall. We have one on coverage and access issues that will be coming up in February. So please consult our website, www.swhr.org, for more information. And with that, thank you all again, and we look forward to seeing you soon.
Thank you.
Thank you.